Oh.
Hello, everybody, and welcome to Hernia Patient Support Group. We're delighted tonight to be joined by Dr. Sara Capoccia Giovannini from Italy. I hope I've said that right. It's Dr. Sara from Italy, who is joining us tonight to talk about complex abdominal wall hernias. This meeting is being recorded by Hakan and it will be available later in YouTube for people to watch. If you do have any questions, if you use the chat box, we can always ask Sarah those. So, Sarah, thank you very much for joining us tonight. We really appreciate this, your
Hello
time.
to everyone. I'm very happy to be here tonight, and I hope to be helpful for all of you and to answer properly to all of your questions. And I try to make it more easier than I can, and even the topic is not easy at all because it's complex, but we try to make it for you if you want.
Okay, I think one of the first things we need to do is understand what is a complex hernia.
It's not very easy to answer to this question because we tried with a lot of experts in abdominal wall surgeries last year in a paper we published with some of you inside of the authors list.
Yeah.
And we collect a lot of criteria explaining what is a complex abdominal wall hernia. But at the end of the day, the complex abdominal wall hernia is something that could be not easy to repair, that can be hard to prepare for surgery, and in the postoperative course of a complex abdominal wall repair, all can be very unsafe for patients, and it should be recognized for us, and you should be prepared for that. So the first question is at least the hardest question of all the night, because in reality we something know about this topic, but we cannot to know all the complexity in itself. We collected a lot of criteria regarding the patients that and the comorbidities of patients are important for us, and we can manage some of the comorbidities, some of the aspects of the patients, but some other things that we cannot manage and we have to accept, and it increase the risk of the surgery itself. And other criteria of the complexity are related to the defect. For example, a large hernia is a complex hernia, but we cannot ignore the fact that it's not only the dimension of the hernia to make complex itself. Because if, for example, a patient had 3 times of tentative of repair of an abdominal wall hernia, it makes it complex for us. And the complexity of the abdominal wall repair is made by some factors. We can study some of them, but we cannot have to completely remove the complexity factors for the preparation of the patient before the surgery.
Thank you. So I'm guessing when it gets a bit complicated, not everybody's all right to be able to repair these, are they? These are the sort of hernias that should be repaired by specialist surgeons who do a lot of these.
Yes, because recently the abdominal wall surgery is recognized by the surgical communities as subspecialties with some of criteria that could be improved. But in last years, abdominal wall surgery was something that everyone can make. But in recent years, the complexity is increasing in our repairs, and it is something that is be aware by general surgeons. So Yes, you are totally right, Jackie. Complex abdominal wall repairs cannot be performed by every surgeon, and even in abdominal wall surgeons, no one can be able to repair very difficult cases, and only very expert surgeons should be, because it's unsafe for the surgery and for the patient in the postoperative course, because it's not only the procedure itself but is the postoperative course and the possible recurrence and all of this part of the procedure and the postoperative course should be studied before the surgery. And even to not recommend a repair is could be a good option if the surgeon is not adequately prepared for the managing of the patient. It's not just an hernia, it's the patient with their hernia and should be in some way recognize that.
Yeah, it should be recognised. But how do patients find these expert surgeons?
It's a difficult part because in the community of abdominal wall surgeons, we know each other. So
Yeah.
if I know that you have to be operated in Spain, I can advise to you some Spanish patients, good surgeons. Um, your work, Hakan work, and the all works of the European Hernia Society is to enlarge our community and to be in some way prepared for all of you in all over the world. And hernia family is really an hernia family. So for the future, I think that in the European Hernia Society site or social media could be a very large mesh for community in for recommend some of us for all of you.
I think
I
that's
think it's very important.
I agree with you. That is something that will be an ideal situation in the end, that we have a list of surgeons for every country who are available for complex hernia
Yes,
surgery.
but we are working on that. But it's my cat. I'm
It's
sorry.
going to be a work in progress, isn't it?
Yes, and the important part is the possibility to add to the list very prepared surgeon and certified hernia surgeons. So the educational program by the European Hernia Society and the collaboration with other societies all around the world, it's working on that to certify all surgeons and to make every surgeon's prepared for every patient because the social media and the availability of a lot of videos on YouTube and something like that is something that is very useful for the training, but it's something that could be also used carefully because abdominal wall procedures can be, of course, very easy and it's something that some young surgeons like me can be perform at the very beginning of their career. But when the procedure moves more complex, preparation and training properly with mentors and proctors is crucial because
Yeah.
it's like for general surgeons to perform pancreatic or liver surgery is something that is recognized as very specialized, very difficult, very important, and is respectfully think about from the general surgeons, and it's something that is equal in abdominal wall surgeries. Complex procedures for complex repairs should be in some way respectfully touched by all surgeons.
Yeah, we tend to recommend it in our Facebook group that patients question their surgeons and even ask if they've been on one of the European Hernia Society abdominal wall courses and done some of the training in the abdominal wall repair, because at least that shows that they're interested enough and they're keeping up to date with new techniques and new procedures.
Yes, in recent years, a lot of procedures and anatomical reconstruction are going up and we are very excited about that because are helpful for our work, and we can improve our knowledge and our surgeries every day. But it's something that is growing really fast, and it's like strange for something that for someone that is not aware about the new, and there are a lot of new meshes, new materials, new techniques every day.
Yeah,
So
everything.
it's something that needs a proper preparation and a proper training. It's nothing that could be improvised. I don't know.
Sarah, is
Yes.
there an unwritten rule where the patient goes in, sees a surgeon, the surgeon looks at the case, and it may be a very large incisional hernia,
Yes.
and maybe the surgeon has never done one of them before, but is there a case where they look at that and they say, that looks like a challenge to me, and maybe I should refer it to a specialist, or I'm going to give it a go, and then it fails?
I think that now young surgeons and new generation of surgeons are aware about the fact that abdominal wall surgery is something that could be looked with respect, because messed up with patients is something that could be real, and it's not so strange to have a patient in a postoperative care unit, intensive care, after a surgery, after a complex abdominal wall surgery. And there is we have to have clear in mind that hernia is not cancer. It's a benign condition. For sure, it's a bad outcome on your quality of life, but it's not dangerous for your life. So if I can fix properly and I'm not prepared to all of aspects of the surgery, I think that for a benign condition, it's better to not perform the surgery and stand up my hand and not touch, and refer for surgeons with very large experience, because for sure, for cancer is another stuff. I have to operate you. Otherwise, there is no other way to fix your problem. But hernia, it's benign, and we have to have clear in mind that fact, because it's important, I think.
Sarah,
Yeah.
along those lines, so in my particular case,
Mm-hmm.
my first surgery was, I had a very large incisional hernia. I had a bad accident, split wide open, spleen out, all that sort of stuff. And then I ended up with this massive, really, really big incisional hernia. So the first surgery I had, it was a tag team between a general surgeon, it wasn't a hernia specialist, and a plastic surgeon. And they decided, and I don't know why they decided this, and even I've talked to Mr. DeBow about it, Andrew DeBow. They
Mm-hmm.
decided to take a flap from my left leg and try and bring that over to do the close. No, anyway, I was on the operating table for 12 hours. They told me afterwards it was touch and go all the way through for 12 hours. It failed. I woke up to them dangling leeches on my stomach to try and stimulate blood flow. But anyway, it failed. I ended up with a deformity now in my left leg where they took the flap out because there's a huge, huge chunk of leg that they took out to try and close it. So I'm just wondering, I mean, I've asked this question before. Is there defined guidelines to say where you would go for a flap before you would go for obviously a closure with mesh? Or
It's something that is strange, because now we have a lot of guidelines, but guidelines are not the substitute for common sense, good sense. So in complex hernia surgery, we have to be prepared for plane A, what I have to do for perform, and what I want to do. But when I have something that is not expected before the surgery, and I have you sleeping on my table, I have to be prepared for change my plan. And it's something that could be not improvised. And general surgeons and plastic surgeons could be a good option for hernia. I can say nothing about that. But when you take the wrong decision to, for instance, do not put the mesh or put something strange, something like biological mesh, because the general surgeon is always fear about the infection of the mesh. And when some years ago, 20 years ago, biological mesh were available on the market, a lot of general surgeons put very expensive biological mesh because every one of us was happy to be prepared to fight to infections and contamination. But it was not the really important and the reality, because biological mesh now we know that are increasing in recurrence. So,
Edwina, sorry, Edwina, can you just mute your there's a lot of background noise.
So training sessions starting to do the back. And now then, you guys have
just put your computer on mute if you can. Thank you.
Okay.
Sorry.
And no problem. So to make the good decision in the OR is not easy, and I think that a good surgeon should be always prepared to not burning bridges for future. And it's something that could be very important for us. It's a problem solving every day. Every case is different. We have some pilaster. We have to know that, because surgery is surgery for sure. But it's a tricky type of surgery, abdominal wall complex in particular.
Do you often do complex abdominal wall surgery as a multidisciplinary, so you involve other disciplines as well?
For sure, it's totally multidisciplinary, because for instance, we have to prepare our patient, optimize their condition. So in the preparative course, you have to gain the weight loss, for instance, because another stuff that is important for the surgeon. Abdominal wall surgeon knows that obese patients are the worst possible patients to repair an hernia, because they have an increasing risk of postoperative complications, also bad complications, something like pulmonary function disruption and something like that. And for instance, surgical site infection of the wound. So obesity control and weight loss is something that is very important for us. But for general surgeons, it's not the same perception of the obesity. So this is one of the other stuff that differentiate our general surgeons from abdominal wall expert surgeon. So back to your question, Jackie. Yes, abdominal complex surgery is something that is multidisciplinary. We have to involve radiologists for the correct diagnosis and for a correct planning for the surgery. We have to involve anesthesiologists, because it could be something that could be prepared before, and physiotherapists for planning the rehabilitation and the postoperative course. Nutritionists, also dietetics, and maybe plastic surgeons, because complexity in the abdominal wall repair could be also included the wound care. And the cosmetics is something that is important after the surgery, and could be helpful to be with a plastic surgeons for a proper flap of the skin or something like that. And in some countries, colorectal surgery is something that is totally different from abdominal wall. In my country, we have a general surgery program, and we mainly prepare on colorectal surgery and something like that, like abdominal wall surgery. But for instance, in UK, abdominal wall surgery is totally different from colorectal. And when you're facing with a peristomal hernia, you should be together with the colorectal surgeons, for instance. So yeah, it's a totally multidisciplinary work.
Yeah, I think what you said there is quite right, that with these complex hernia, as with any hernia, rehabilitation and getting ready is so vitally important, isn't it? And we talk a lot as well about, as weight loss is one part, but also stopping smoking, because that leads to very poor wound healing, doesn't it?
Yes, the smoking cessation is important for all your life, and in particular for preparing to a surgery, abdominal surgery or every kind of surgery, because smoking is impairing in wound healing, and the abdominal wall surgery is based on the wound healing, because incisional hernia is mainly related to impaired wound healing after a surgery, after an incision that is not properly wounded. So smoke, diabetes, the obesity condition, steroids, drugs, and immunosuppression are factors related to the impairment of the wound healing. So there are some factors we can manage: the weight, the diabetes control, the smoke, but something else that is not can be managed, steroid therapy for cancer or something like rheumatologic disease, we cannot manage because we cannot avoid the drugs. So the important part is to work on what we can improve, and when we advise patients to stop smoking, it's not for be bored, just for optimize their condition. And if a patient cannot stop smoking or cannot reduce their weight, it's not a problem. We can wait and postpone the surgery. We can wait for our patients. It's not the surgery that is mandatory for the hernia patient, because it's a benign condition. So we have time. But this time could be helpful for patients and could be not recognized as, okay, my surgeons want to operate me. No, it's totally different. We want to improve your condition to have less possible problems after the surgery or during the surgery.
Yeah, you're not nagging for the sake of nagging. There is a reason behind it, isn't there? So what is the role of Botox in abdominal wall surgery?
Botulinum toxin A is a drug that is no new in the world of the medicine, but is quite new in the abdominal wall surgery. It makes the abdomen paralyzed. It's flaccid. The flaccid paralysis of the BTA is the same of the aesthetic surgery, not different. And it's make easy to close the abdomen. So when we manage a very large hernia in the midline or in other parts of the abdomen that disrupts the core, the midline, it's important for an anatomical reconstruction and a functional abdomen to close the abdomen and have, again, the two rectus muscles closed. We can have these closer mainly with two procedures. The first one, the old one, the component separation, that is very disruptive. It's helpful for us. It's an anatomical reconstruction. It's a genius procedure. It's something that changed totally abdominal wall surgeries. but it's very difficult and it's very disruptive, and it's not totally clear of complications for the patient. And it's something that now in abdominal wall community is very clear. And the second, but is something that we are studying on, is to use Botox, injection of botulinum toxin A preoperatively, in order to have a relaxation of the muscles of the abdomen that facilitates the close of the abdomen. And for now, we have running a lot of studies, and we are collecting a lot of data on patients that we closed with the botulinum toxin, avoiding the use of component separation, that is a traumatological surgery. So the results are promising. We are studying. We have to collect more evidence in order to recommend to use the botulinum toxin. For now, we have another problem, that is the fact that is not allowed to be used in all countries. For instance, in Italy, is off-label for abdominal wall surgeries. So it's something that the surgeon and the patient should be discussed. And I prepare the patient for the procedure. For now, we have data about very low complications on the injection and very low side effects from the drugs. But it's something that the patient have to pay the vials of the BTA in Italy. And we have some problem about the coverage of the insurance for possible complications or something that cannot be perfect. So in my center, for instance, we never performed the BTA because there are some legal problem. But in UK or in Spain or in other part of the Europe or in USA, for instance, BTA is very useful and helpful for patients. And the possibility to avoid massive surgeries is important. So
if your doctor doesn't use Botox, there's something like fascia tens, isn't there, that you can use as well?
Yes, it's a genius procedure.
It is.
Yes, fascia tens is a new device. It's born in Germany and is a machine that tense the part of the muscles intraoperatively and with elongate the muscles can be closed in the midline. It's something that is very helpful for patients and for surgeons, and we are collecting also in this case data because we have to have evidence to recommend it in guidelines or in clinical common expertise, and it requires a little bit of time for the future. But the results are promising. We are happy to avoid component separation if we can.
Yeah, it looks a strange contraption, but it really does work, doesn't it? And what I liked about fascia tens when I spoke to them is they won't sell it to anybody. They'll only give it to trained people.
Yes.
They'll come out and show you how to use it first, so it's a safe procedure for patients.
Yes, it's safe, and it's something that remind the cure of open abdomen in emergency procedure when the patient is very sick. It's not safe to close immediately after the trauma surgery the abdomen of the patients because it's not safe. The patient is not stable, so we can leave the abdomen open, but it's a problem because if a patient stay with the open abdomen 3 days, 2 days for take care of their condition, we cannot to close after 3 days. So we use fascial traction. that is something that when the patient is the intensive care unit and he sleeps, we track the fascia, the two board of the abdomen, we close progressively in 2, 3, 4 days, and it's something that it's effective.
Yes, it is very effective.
Yes.
So, incisional hernia tend to be the more complex, don't they? When I talk to patients about these and they ask me, is mesh always necessary? I think that my theory on this is that we've already had a mesh-free repair when we had the original operation and that failed. Is mesh the right way to repair these complex hernias?
The mesh are the device that totally changed the hernia cure, because before the invention of polypropylene, the material that we normally use for repair an hernia, the recurrence rate was totally insane, 90% and something like that. So the use of prosthetic materials and the mesh materials are very important to reduce the recurrence and to give the best option for our patients. A lot of materials are available on the market, but normally we use all of these type of meshes are safe for patients. For the first of all, they have to be safe. So not cannot be in some way replaced without the mesh, because the repair is not it's not complete without the mesh.
No.
So for sure, our advice to use mesh is for grow the safety of the procedure and to be effective in our procedure.
What about these newer meshes, the ones that are like a temporary mesh, the biosynthetics?
Yes, are very new, and we don't know if are the good option in case of complex cases, because are temporarily. Biosynthetic meshes are divided mainly in 3 categories: synthetic permanent mesh, polypropylene, there are plastic mesh, there are stays in your abdomen for your life and are safe and are the oldest one. The second one are the biological mesh made by porcine or ovine materials, safe, but very temporarily, because they disappear in 1 year, more or less, even faster when infected field is present. So there are maybe a good option in case of infection, because there are maybe resistant to infection more than polypropylene, but that maybe are not effective in case of recurrence. So the market have a third option that put together the biosynthetic mesh. They are temporarily absorbable. Probably could be the solution for the future, but I don't know if I want to repair definitely a complex abdominal wall hernias. I'm happy to have a mesh that disappears in 6 months. Because when I repair a complex abdominal wall hernia, I want to be the last time in the surgery.
Yeah, completely agree. Completely.
Because otherwise, I don't know if I can do the best for my patient. So I'm too young to answer to this question, I think, but biosynthetic mesh could be an option, but we have to study about that.
Not enough data yet.
Can I ask a quick question there, Jackie?
Yep.
Sarah, before an operation, are you able to determine if there's not infection visible to the surface, but are you able to determine if there's infection upon, obviously doing the surgery, splitting open, you find infection in there.
Mhm.
Are you able to determine that before the surgery?
We can imagine, but it's what I said before. We have a plan, but if the plan go wrong, we have to switch our plan. Infection is something that could be imaginable from us for the history of the patients. For instance, if he had 3 meshes inside the abdomen, the risk of infection is higher than a patient that only have a massive hernia, for instance. Or if when we perform the surgery, there is an unexpected contamination because adhesions or something like that, we could change our plan. But I think that for now, the safety of the materials and synthetic materials are very high. The resistance of infection is quite higher. 80–90% of the mesh can be safety used in contaminated fields. So now the evidence are quite changing, and our practice it's very evolving. 10 years ago, maybe there was the rule not to put the mesh in emergency surgery. Now we are writing the guidelines on emergency surgery recommending to use mesh in incisional hernia if the contamination is not prohibitive. So part of complex abdominal wall surgery is the ability to change the plans when we are facing on problems. And this is why it could be recommended to repair complex abdominal cases only if expert, because otherwise there could be a problem for patient.
Yeah.
Thank you.
No problem. So when you're doing these procedures, are they always open? Can you do them minimally invasive?
No, it depends on the complexity degrees of the patient and the defect. For instance, robotic surgery, they are growing up very faster in recent years. It's a good option to have the possibility to reproduce open, technically challenging gestures with the ability of minimal invasive surgery to reduce postoperative pain and postoperative wound complication and something like that. The fast recovery of the minimal invasive surgery is guaranteed by the use of robotic surgery coupled with the easier gesture for surgeons. But again, if the hernia is very complex, 4 times of repair, multiple mesh inside the abdomen, after emergency procedures with a lot of contamination, so we expect a lot of adhesions and something like that. Maybe open could be safer for the patient, and at least I prefer to, but I'm young, so it's quite different in expert hands. But if we propose to you an open procedure, it's for your safety and to avoid, 3 hours operation more for attempt to try to repair in minimal invasive surgery and failed or be obliged to convert to open surgery for something that is going wrong. So minimal invasive surgery could be an option, but it's very technically challenging to manage a complex abdominal wall hernias in minimal invasive surgery.
What's recovery like for complex hernia? Because that is something that worries patients.
Recovery could be active by patients. So when you recommend to you stand up from your bed, it's for faster and improving your recovery. Even if you have pain, it's better to have drugs for pain more than stay in bed. And it's something that could be strange to understand for patients when the surgeon come to you, stand up. But it's very important for us that you stand up from your bed after surgery, immediately after surgery. There are a lot of programs that are called enhanced recovery after surgery programs. They are improving from the 90 in Denmark, and now are exploding in all type of surgery that are very strictly on the recommendation of the postoperative course. And for sure, there is something that could be told to you before the surgery. Otherwise, the patient could be something that is not so convincing. Why you are asking to me to go to have a walk after 3 hours after the procedure, but it's something that is important.
Very good. What about the role of binders and support wear after surgery?
Yes, it's something that could be useful also before the surgery, because the binders are not. It's something that is strange because we recommend to use binders before the surgery for the mimic of the procedures itself, and it's something that could be useful and helpful and very good tolerated for some patients, but for others are totally uncomfortable and they don't want to wear anyway.
Yeah, I wear the vests. I prefer the hernia vest to the binder. I find them a lot more comfortable and wearable.
Yes. For someone is helpful to wear a binder or contentive wearing clothes. It's something that could be helpful. After surgery, recommendations are quite low evidence. It's just common sense. We recommend in our guidelines to use binders after surgery, mostly for 2 reasons. The first one, to relieve the pain on the abdomen, because muscles are very traumatized after surgery. So when you push with your binders, some pain could be relieved. And the second one, the use of compressive clothes can help and reduce the collection of the fluids under the wound. So it's something that could be helpful for the patients for the pain relief and the wound care. There is not a very recognized time and period to use after the surgery. In the guidelines, it's recommended to use after 6 months for 6 months after surgery. Normally, we recommend to use it in 1 month after the surgery. But it's something that is very different in every center, every city, every country. Every surgeon can be a different advice.
I think with the binders, especially after you've had hernia surgery, they give you confidence when you are starting to walk as well. That's one of the benefits. When you're becoming more active, the binders give you the confidence that your wound's actually going to hold together a bit.
I found the binders very useful, Jackie, after the Botox injections.
Yeah.
The only side effects, I've had them 3 times now, the Botox, 3 injections each side. What I found after about 2 weeks, my stomach was heavy enough anyway, with obviously the way it was, but with the paralysis setting in, it became even heavier and heavier.
Yeah.
So I found the binder very useful after the Botox injections.
I must admit, I bought one after the Botox injection.
Yes, because Botox relax your abdomen and have something that push all together and reinforce the core. And the mimic of the procedure is something like equal in some way.
What advice would you give to somebody whose hernia is not operable?
Trust in the surgeon that then want to operate you. Trust him to not seek for surgery in any case, because the complex surgery and complex abdominal wall surgery is not feasible for everyone. So my advice is ask why. Why do you want to not operate me? Because if the answer is I'm not able to do it, okay. And the second question that I advise to give to the surgeon is who can be able to perform this surgery. And as we said before, ask to EHS, to you, Jackie, or something, someone that can be prepared on who are the best surgeons in each country. The second problem and the second reason to not operate a patient could be not optimize the condition. And in this case, trust twice to this surgeon, because if a surgeon don't want to perform the procedure because it's too risky for you, he is a good surgeon. Every time I think that the hardest decision for us is to not operate a patient.
Yeah, I understand that.
And this is the difficult part of the job, I think, and this is the difficult part to learn when to say no. And every time the surgeons say no, it's a good surgeon, I think, because he recognized the problems. Where is the problem? And general surgeons and not abdominal wall surgeons could not be able to say no because they are not aware about the problems of this kind of surgery. Because when I have a patient with 3 multiple recurrence, with obesity, with parostomal hernia in emergency, I'm scared. And I don't want to perform the surgery, not alone, not in my condition, not in my hospital, and make it easy to me to say no. It's not the moment. We can wait. We can optimize your condition. We can prepare for the surgery. We can to have a plan. But a general surgeon that don't know what is really a complex hernia, because it's not aware about the problems in the surgery, about the problems in the postoperative course they don't face, about the ICU unit filled by hernia patients. He is not prepared to say no with a patient with an hernia.
No. People that we see tend to get worried that they're still feeling pain from their hernia repair after a month or 2 months. And I don't think that's unusual, really, is it? It can, you know, it's never going to be the same as immediately after surgery. It's going to be painful. It's always going to be painful, but you guys can manage that pain with a good pain management plan. But there is the chance that there's always going to be a little bit of pain and discomfort for a couple of months afterwards.
For sure. Pain is one of the scared part of the surgery for everyone.
Mm-hmm.
And pain is something that is not objectable. It's subjective. And when my patients say to me, I have pain, it's something that I have to believe it. I cannot measure or scan with something. So in complex cases with multiple scars on the abdomen, and in case of component separation, something like that, when the muscles are really traumatized, muscles are very painful after surgery. Mm-hmm. After a complex abdominal wall surgery, muscles are disrupting because we have a lot of dissection, and it's something that is painful. We can fight the pain with drugs, and I think that a good advice could be take 1 drug more and stand up without pain, and try to fight the pain with drugs, and not try to
don't be brave, don't be a hero.
Yes, not to be a hero. There is not a gold medal for pain killers
Yeah.
without drugs. So take your drugs and go. And binders could be helpful. And something that could be helpful is to be prepared. If I say to my patient before the surgery, okay, it's not important, it's a joke, we can go to the surgery, it's easy. The patient is not prepared to
No.
what they happened after the surgery. And when I scare my patient before, because I don't want to have a scared patient in the OR, but I want to have a prepared patient in my OR.
Yeah, I completely agree.
I prefer a patient that think I'm crazy and give my outpatient clinic and say, bye-bye, Sarah, I don't want to have the surgery with you. But I don't want a patient that is totally not prepared to all this stuff. Because if the patient have a surgical site occurrence, a seroma, a big seroma, and he had to give me 3 times, 4 times a week for the medication, for the wound medication. And I never tell to him before.
Yeah.
He thinks I am mad.
Yeah, no, I think information and getting all the information from your surgeon.
Crucial. It's crucial
very,
to
very
receive
important.
information. And with the European Hernia Society, we have to prepare. We are preparing for you some materials and documents for every kind of surgery.
Yes,
and
it's great that. Yep.
I think it could be important for you have a website and download it in each language.
Yes.
We have to translate it in several languages for be intuitive for all of you.
I think that's brilliant. Is that one thing? What we find that patients report a lot that ice packs help. If after surgery, if they put an ice pack and use an ice pack against the wound for about 20 minutes a few times a day, that can help reduce pain as well.
Yes, it's something that could be useful, but I think that could be decided with the surgeons.
Yeah.
I cannot have an advice generally for all of you.
No, that's fine. Oh, I can't believe it. It's we've been nearly an hour now.
Yes, time flies.
It has flied. So, does anybody have any questions before we let Sarah go? No. Well, thank you ever so much. Oh, there we go. Deborah has said grazie.
Also in Italian.
Deborah said grazie mille. It was so interesting and very, very useful. Thank you.
I'm happy.
Yeah. Thank you ever so much, Sarah. That was a really interesting.
I'm very happy to be helpful for you, and I'm very enjoyed this time for you.
Thank you. Take care. Thank you, everybody, for being here. Take care.
Bye-bye.
Thank you, Sarah. Thank you, Jackie.
Sarah. Thank you, Jackie.
Thank you.
Amazing. Bye.
See you. Bye-bye.